for introduction just there. And yeah. Yes, this is not mine. Okay. Don't worry. So, very nice roundtable on a topic which is changing very quickly in the last few years. If I compare what happened in the last 15, 20 years, that is very modified. And so I know nothing to discuss. So, as we know, goals of stone treatment children is to achieve complete clearance by minimally or not invasive single procedure, which is not easy, and avoid open surgery. But so recently, quick evolution of technology and of procedures have been seen. So where are we now? We would like to focus where we can do what we are doing, which are the new things that are arriving with some experts. So consider that we have 3 different ways to reach the stone. Diet, renal percutaneous chest, by mini or micro pack, retrograde ureter access, ureter or little bleeding, or retrograde intravenous surgery, or the new step, flexible ureteroscopy surgery. We could combine the two, and then also the laparoscopic chest to transfer to the airway. So this roundtable, we have Adam Malicki from Poland, Stefania Ferretti from Modena, and Mario Gucci from Vicenza. We could discuss the new things for children treatment, but I will give you some little tips. So some new tools are arriving. For example, balloon dilation is safer in our experience and less bloody. We recommend that, less traumatic. And we use now the trilogy lithotrust, which is combined ballistic ultrasound energy with aspiration, which gives very nice results and a beautiful view for the scopic treatment. We do prefer now the mini bag for many procedures. This is our equipment. And we do use the clear filter system, which is a new one, which has the facility to attract the little stones and the power, and to increase the visibility during our procedure, and with laser as well. And we do like thallium laser, and for retrograde ureteroscopy, we like the new flexible ureteroscopy with the new sheet. The new sheet, very nice, very nice view, also a bit costly. The point is the cost of this kind of procedures. So, finishing my introduction, I have to give you some messages. Which stone I deal with? We must look in pediatric metabolic methodological study. We have several metabolic stones, cystine, but also solution. We have to study which kind of stone we have. How the uterine and piedocalicial neurological anatomy is never go without the study of anatomy. So we have to study preoperatively the anatomy of the kidney and the urinary tract. Which is the best way to reach the stone? So we have to design our most efficient embryological strategy. If I have an expert event, so consider before starting a possible second extra way. What can I need? Prepare all the necessary instrumentation guide-wise. Prepare flexible endoscope when it's possible. And so, anyway, be always soft and flexible in embryology, never traumatic. Smaller and modern microscope still scanning. Sometimes I don't think it's really better. So sometimes I have to stop for the small capital. Have a good vision. Not drive blind. Never blind. So, seems to be stupid, but it's not so stupid. Avoid high pressure inside the tractor. Respect their parenchyma, especially in younger infants and children. And then the last 10, do not force any maneuver. Be soft and smooth. The urologist must adapt during the calcium system and not the company. Finally, what else? Oh, how many recommendations? How boring I am. Achieve stone prestage if possible. Second, the endoscopy could be wide sometimes. Don't be extensive. Avoid oversurgery. Don't be unhappy. Keep calm and patience. Be picky and delicate. These are my tips how to manage it. Whatever you want to do. Anyway, so this is our roundtable of new technologies, changing this, but these principles I think must be stable in our minds. So thank you. I think I finished my presentation. Because I was looking the history of the endoscopy. I didn't remember open Bivar in effect with. So, please, Adam Alski is coming from Poland. He will present new tools.
I would like to thank you, Marta, and the organizing committee for inviting us. If I can have my presentation, I'm already connected.
So my recommendation would be probably I think that we have to move my hands always after moving the brain, and not vice versa. Okay. Thank you, Lucas. Innovations are so quickly arriving that we have no time to adapt our technical movements to the new things that are arriving. This is for all, for laparoscopy, for endoscopic treatment. But any trouble? Because time is run.
Just technical.
Do you prefer to start with the second presentation, then you try to set up your PC? How many of you do you perform normally with retrograde or percutaneous treatment for stones? I think it's not so common in pediatric surgery units to do such kind of surgery. How many do stone treatment with scopolamine treatment? Can I ask you, that's not so many. Yeah. Because we need some connection with the adult neurology. Absolutely. Technical equipment for increasing our capacity. If you want, we could go ahead with the second presentation.
Yeah.
Are you okay, Adam?
They are trying to do something.
But could we go to Martha, you think I will go with the other one?
Yes, sure.
But the problem is the same.
No.
Because we missed the advantage to start the we can.
Okay. Hold on another time.
We can go ahead and read Stefania presentation.
Podemos saltarnos así a su speaker.
Yeah, Stefania, I read
Stefania Ferrer.
I introduce Stefania, which is my friend, adult neurologist. She's doing pediatric neurology as well from Modena University. She's very famous for all the endoscopic procedures in so I have to thank her for coming here to give her experience in the treatment in difficult cases and pediatric cases. Thank you, Stefania.
Thank you, Paolo. It's a pleasure. I'm very happy to be here in another kind of world. And speak to you about PCNL and percutaneous approach, combined percutaneous approach in children. When we look to the indication are the same as in adults, also in children for PCN approach, and of course for the stones much more than 2 centimeters, or sometimes also smaller if there's no possibility to perform a shockwave lithotripsy or recurrence after shockwave or after ureteroscopy treatment. And as you can see, the stone-free rate are very high, between 71 and 95%. Also, the complication rate is not low, but if you look at this complication, you see that they are lower than 1-2 Clavian-Dindo classification. So it's not a big problem. And today, the miniaturization of the instrument, as Paolo said before, helped us to perform also percutaneous in very complex cases with minimal approach, percutaneous approach. As you can see also in the guideline, the percutaneous is indicating in stegon stone calculus, pelvic stone 1 than more than 2 centimeters, also in combination with the lower calyx, and sometimes also for stones of 1 centimeter and more, because sometimes there is a problem of malformation, of difficult to the expulsion of the fragment after, for example, a shockwave lithotripsy. And there is a literature about the importance of the percutaneous approach with respect, for example, to the retrograde intrarenal surgery for, of course, the same barb, the stone barb, and also the possibility to, in Also, when we look to the lower calyx in combination with pelvic calyceal stone, the mini PNL approach has a higher stone-free rate in the first section, and so there's literature who say that it's better to perform mini PNL than, for example, shockwave lithotripsy in several sections, and so on. There's also literature about the stone management in stegoral calculus. There is literature in favor of the percutaneous approach, and also the important post-op complications like bleeding, they are very low, less than 5%. And we know very well that the bleeding, the risk of bleeding is directed to the number of tract size and the size of the tract, of percutaneous tract. This is the same in the adults. This is a very important paper that confirms that the stone, the size of the percutaneous is directly correlation to the risk of bleeding. So, how to perform in pediatric PNL approach? As you can see, we have to have minimal invasiveness, number of narcosis, minimize the X-ray exposure, and if it's possible, of course, if possible, high stone clearance. And today, as Paolo said before, we have run to the miniaturization in all, also in our society, the miniaturization of instruments, and also in endourology, this is the must. And today we know that it's important to choose the correct access, percutaneous access, respect the endocalyceal anatomy, the clearance, the compliance of the calyx, and also respect to the stone burden. So this is the possibility to use, this is the instrument that I use in adults, and it's the same that I use in children, because today the possibility to reduce the time of lithotripsy, as Paolo said before, with the new generation of combined ultrasound and ballistic source, but today especially the new laser, we have the high potency onion laser, and in particular the super pulse thulium laser. This is a revolutionary, the approach to dusting also a very large stones. And of course, this is the remarks when we approach the percutaneous in a baby. And of course, when it's possible, I prefer to perform a combined surgery with the retrograde access, so-called endoscopic combined intrarenal surgery, ECHIRS, because there are a lot of advantages. This is the position. We changed our approach to prone to supine in 2008 in adults, and of course also in children, even if we know that there is no difference in the superiority of one technique to the other, but and also in our experience is so. But we fall in love with supine approach here in Spain in 2008 with the experience with Professor Valdivia Uria in Zaragoza and Professor Gaspari Barlucea in Bilbao. They was our inspirator to supine approach. The advantages in supine are a lot, as you can see, better respiratory, reduce the surgical time, especially in adults. In children, it's very quickly to move the patient from prone to supine or vice versa, but the possibility to see, as you can see in this immediately, the possibility to see the puncture in the endovision approach is very important, because we know that we are in the correct access transpapilla and not, for example, transingular, and so we reduce the risk of bleeding after the procedure. Of course, supine and combine have some disadvantages, because when we open, when we work in supine, the collective system is empty, but this is an advantage because the fragment go out spontaneously, for example. Of course, we have two equips, two nurses, two equipment, and sometimes also some problem in economy approach. But I think that is very important. I want to show you this video that you can find in Videourology, the Journal of Endurology. It's not recently, it's about 10 years ago, but it's very didactic. This is a little baby, little girl of 2.5 years, presented. And today we perform the same approach as 10 years ago. The different, of course, as I said before, we have more choice in miniaturization approach. This is they remove the presented patient, and then we put an access sheet, 9.5 urethral access sheet, and then we go up with the endoscopic, flexible endoscopic. We see the stones, and now we choose the correct papilla and calyx. In our school, we perform only an X-ray percutaneous puncture in 0 and 30 degrees. We don't use generally the ultrasound approach, even in a particular case, but when the baby is on the table, we perform ever check an ultrasound to see the viscera and so on. Then, if you look to the endoscopic, we see the correct percutaneous access in the center of the papilla, and in this way, of course, this is a didactic video, and so we see also the X-ray, but generally you can follow all the percutaneous with only the endoscopic guide, so reduce a lot the X-ray exposure that in children is very important. At the same time, when we start to fragment the stones, if there are some pieces go up to the superior calyx or in the inferior calyx and so on, the possibility to check via retrograde with flexible and catch with a basket this fragment, so-called pass the ball technique, because I take the fragment and I put the fragment in front of the percutaneous axis, and then the colleague take and follow out the fragment. Also the possibility to inject the water from below to up, it allow the clearance, spontaneous clearance through the access sheets, and the possibility also to perform a tubeless procedure at the end, not in this case. In this case, we prefer to put just a little 12 French catheter, but generally they are a tubeless procedure. So I run at the end of my presentation, so we are in time. And the take-home message are that also in childhood, the PNL is the gold standard for the stone than more than 2 centimeters. And today, laser technology improvement allow fast, safe, and efficient mini PNL approach. Thank you very much for your attention.
Thank you, Stefania. We go ahead if you are ready. Others. So, thank you for thank you. So you see how difficult sometimes it is to have all the materials. Technology is almost complex in this case.
Yeah. Thank you so much once again for inviting us and inviting me. I would like to thank the organizing committee, the chairmans. My topic was the ureteronoscopy in retrograde intraoral surgery in the third millennium. And I have no disclosures. This is the agenda how we change our mind. We go through the laser stents, efficacy about the urological procedures, equipment, what we can expect and what we can improve even from today, and then we'll let me conclude. So first of all, we change our mind. It used to be that we had a surgery, or even most of the open surgery. Then from 1980s we got the ESWO, which we could put wherever we want. But according to the data, we are not allowed to perform the ESWO in the lower part of the ureter. And nowadays, the ESWO is setting a little bit back, and the J-cal procedures are going a little bit up. We have in kidney, we can perform the flexible PNL. In the middle part of the ureter, we have both the ureteronoscopy and ESWO. And as I told you before, we are not allowed to perform the ESWO in the lower part of the ureter, and this is also in the EU guidelines. Right now, the ESWO and flexible ureteronoscopy are on the same level and could be offered as the treatment of the first choice. However, the children still have a very good efficacy of ESWO, so rather ESWO is the first option. Laser. We are all saying laser, but this is an acronym. This is the light amplification by stimulated emission of radiation. And we have started in the era of the 15 volts laser, then we go for the 30, 70. Right now we have the very powerful device, which is 150 volts quanta cyber only laser. And the laser settings, you can, at the menu, you could have so many options to choose from the soft tissue, the or lithotripsy. And according to the two pedals that you have, you can use on the left, for example, fragmentation, and on the right, you can use popcorning, dusting, whatever you want. You are not losing the time to change the settings. However, there are so many settings in the lasers, so this device increases our possibility in the urological procedures. You can adjust the settings to your stone. You can increase the energy, increase or decrease the frequency. At the same time, you can do it with the dusting, forming, fragmentation, whatever you want. However, laser settings and laser warnings, remember that you still have the regulation. There is still radiation, so you should use protective glasses. And remember that with new devices, the time of the procedure is shorter. But remember about the temperature of the water. Put your hand under the output channel and check the water, because when you are involved in the surgery, you are so happy that you can laser the stone. But remember about the temperature. This is very important, especially with the new high-power devices. Laser was a game changer, and it's still a game changer, I think. And we are expecting new devices which will decrease the time of the surgery, which will increase our efficacy. Of course, we can still use the old devices, but why not to drive something better? And stents, ureteral access sheet, guide wires, there are still many new companies which are producing new stents names, new ureteral access sheet names, guide wires, and so on. They are decreasing the sizes of it, but we still have the old problem, especially with the stents, which is an incrustation. You can see here in the scanning electronic microscope, even after the second day, we have an incrustation. This is a very important topic. This is on which we are working right now with my bioengineering department. Try to avoid the incrustation, and also the biofilm is also, and then the UTI is also a problem with stents. So if we can find something, this could be also the second game changer. And the urological procedures in the retrograde and the ureteronoscopy, according to the worldwide literature, is still rising. Where are the reasons? The reasons are like the stone disease. It's multifactorial, so we are performing much more surgery. So if we're doing some more surgery, we are better. We have the better equipment, the better view, and this that's a very good information. Equipment. So we, as my friend Paolo said, miniaturizing is not always the best, but in rears or ureteronoscopy it helps us to perform the surgery even in a small child. We are going rather to the single-use scopes with a good view. Right now the Hulk is we have a very good view, and the price is much lower than the reusable. And where are the game changers for rears? Maybe we also starting with robotics, and we will see what will happen then. Our expectations in the third millennium. So the equipment, reusable, single use, with a good view, more stents, but without the problem of incrustation and the biopsy. Equipment which will measure the pressure, which is very important, especially in children. We need to have reference center, alarm protocol to achieve the goal and to lower the radiation dosage. Also the faster diagnostic process and cooperation between urologists, and those last two are here because if you have a fast diagnosis, good cooperation, you could have easy procedure, easy. Not so easy, but not so difficult. You can achieve the stone, you can make a fragmentation or testing, but if you will have the long-lasting process of diagnosis, you will have the situation like you will have here on the right, like the stone which was ingrown in the ureteral orifice. On here, as you will see in a few minutes, as you can see here, we have the stone ingrown, and this is the game changer. If we won't have a laser, we will not be able to do the surgery. We have to go for the lab or in the past to the open. And here on the right, you will see the edema of the ureter. This stone was in the ureter up to 7 months. So the child weighed 7 months with the stone like that, with the edema of the wall. And after such a time, after surgery, all we will have, of course, the stone rate high, but there is a high possibility of the stricture. So be fast as possible. What we can improve today? So we can increase our knowledge and skills. We can decrease the number of procedures, avoid some ESWL session, go for the urology. This is the third millennium. You can go to the hybrid operating theater when you have a possibility to perform all the procedures at the same time. We have the good cooperation with cardiological departments, so they allow us to go there. We need to standardize the procedure. So before you put the ureteral access sheet, make ureteronoscopy. Be sure that there is no stone, and you will not have a problem when you put the ureteral access sheet into the patient. This is one of the follow the rules, as Paulo said. Never force. Be gentle. If you have a problem, put the DJ stand. This is also the third millennium, and this is smart and nice move to be gentle and polite. This fluoroscopy on such an operating theater is very good for us because you can narrow the band of the radiation, and you can just make a fluoroscopy only of the kidney. This is very important. And as I told you before, here you have the ureteroscopy before the ureteral access sheet, and there is a stone in the ureter. Decrease the radiation dose according to this possibility of the radiation, and create the stone centers with the stone feeding like pediatric nephrologists, urologists, dietitians, nurses. This is the goal of the third millennium. So in conclusions, the laser devices increase and extend our possibility of endoscopic treatment. There is the constant progress in the urology devices and utilization help us in performing ureteroscopy in a very small child, and follow the urological rules and be safe with this. Remember that you have also the possibility of the DJ stand and to come back for the surgery. So just thank you so much.
So difficult things, new technology, new devices, more experience with it. You present. Please. Thank you for your welcome.
Okay. Good morning to everybody. I'm very honored to be here and I'd like to thank the organization for this great opportunity. So, my difficult role is to speak about the transretroperitoneal approach in identification and the limits of this surgical approach. We are here because the lithias in pediatric population are increasing in the last year. It's very important to treat, and in the previous report we have seen what can we do in our endourological technique. And my role is to identify the situation when minimal invasive surgery, trans or retroperitoneal approach can help us to treat this complex pathology. We don't remember that the treatment of the kidney stone in pediatric ages cannot be improvised but requires a perfect knowledge of the all available technique in a center that take care of this patient. So, when we consider the minimal invasive surgery, obviously not in the previous instance, not in the initial instance, we can consider it when the neurological techniques are not adequate in pediatric population. And when it happens, when the baby is very small, they have a very low weight, when we have a large and impact pelvis and large ureteral stones, especially in a little child, when the lithiasis is in conjunction with anatomical anomaly of the urinary tract, like also kidney on that system, and when we have a complex stone, when we need a lot of multiple treatment endoscopic, and when we are in synchronous UPJ obstruction, and when the endourological technical fails. So, in this report, the EU guidelines of 2006 can help us and to identify the indication of the laparoscopy and surgery in case when the endoscopic technique failed and the large impact stone in the high role, the minimal invasive surgery. So in literature, it's not very definite indication of the approach that we can choose. We know that the approach available are the transperitoneal approach and the retroperitoneoscopic approach. So, our experience in many years of practice, in many cases of practice, can identify obviously the specific characteristics of this technique. About transperitoneal approach, it's a more spreading technique. We can have a very good surgical space. It can be an easier approach. Can we have a good exposure? Yes, but we need to mobilization the intestinal wall. About the retroperitoneoscopic approach, it is very important to have a very good experience in this space, in this retroperitoneal space. It is a physiological space, and we don't need the intestinal mobilization. So, which approach to choose? The experience about these two approaches can allow us to identify a situation in which we can choose one or the other approach. About retroperitoneal approach, we prefer to use this approach in large stone or complex stone of the pelvic situation, especially when the pelvis is very small, and this can happen in lithiasis. This approach, this choose, is because we have with the retroperitoneal approach a direct access to pelvis, avoiding the vascular hilus. So we can opening with very greatness the pelvis, we don't touch the hilus vessel, and this is very necessary to remove a very big stone. We prefer the transperitoneal approach when the lithiasis is in conjunction with the ureteral-pelvic junction obstruction, with the hydronephrosis, because we think that if it's necessary, the pyeloplasty is easier with this approach, and we use the transperitoneal approach in ureteral lithiasis. In this particular case, with multiple site lithiasis and ureteral lithiasis, its fundaments are to properly plain surgery, because the transperitoneal approach allows visualization of all the ureter, but in the retroperitoneoscopic approach, we are limited access to the ureter tract under UP injection. So I show you some examples, some complex examples that you can think about minimal invasive surgery, a young child with a metabolic lithiasis, and another child with an anatomical anomaly. in a situation with obstruction and in necrosis, and in recurrence after endourologic technique. So I show you the video about these two approaches. The first one is the transperitoneal laparoscopic peritoneotomy. You can say that the first thing that we have to do is to mobilize the pelvic flexure to have access to the kidney and to the pelvis. So with the sealing, we can open the renal space, because we have to have a very good exposure and a very good space to maneuver, to open the pelvis. As you can see, as I explained before, in laparoscopic transperitoneal approach, we find the vessel in front of us. We can isolate the ureteral tract, and then we can open the pelvis. We can touch with the instrument the calculus, and we can open it directly where it is, and then we can remove it. Normally we can choose this approach when the calculus is very, very big. You can see that is so difficult because the calculi is very attached to the pelvis. And it could be necessary making 2 or more times to remove definitely all of the impurities. Then we go to the suture, in continuous suture. Okay. I show you the retroperitoneal approach. In our school, we think the retroperitoneal approach are very exciting approach, but it needs a very big experience about this. I show you as Dr. Chiarenza opening the space and consider the access of the retroperitoneal site. Okay, so dental, so under vision is important to identify the space. Okay. We put the other trocar, and there we go to exposure our side. So you can show. I would like to make your attention about the condition of the tissue that we find in laparoscopic and retroperitoneoscopic approach. When calculosis is present, the tissue are very inflammation. We can see now the open the pelvis to identify the calculi that this was a cystinouric calculi. And then we remove and we perform the suture in the same model of the laparoscopic transperitoneal approach, but in retroperitoneoscopic it is more important to not mobilize the kidney, because if the kidney falls down, you can see anything. So it's important to don't mobilize the ring. So, what are the favorable aspects in minimally invasive surgery? I see that we can use it in a low age and a small way. We know that in some neurological techniques are difficult to make in very little patients and are not free from complications. We don't make any parenchymal trauma. We can control very well the bleeding risk, and if you have some complication, we have a very good vision of the situation. The technical aspects are very important, and the minimal invasive surgery in this situation is a very higher stone-free rate and is definitely a treatment. We can consider it the minimal invasive surgery like one shot, one kill, but be careful, because we have to keep in mind that this patient that we're going to treat is a person based on a metabolic pathogenesis with a very high recurrence. Another very important aspect that I show you is we can resolution the underlying pathology, such as obstruction of the urethral junction with dismembered pyeloplastic or non-dismembered pyeloplastic for partial stem. But please don't remember, I show you the video, that in this case the pelvis is very inflamed, the thickness of the suture are at high risk of leakage and the sequence anesthesis. So don't remember, it's a very demanding technique with a high complication risk. Another favorable technique we are speaking about the previous before, that the laparoscopic approach. reduces significantly the radiological exposure, that in patient pediatric population is a very important aspect. But we have some controversial aspects. Some limitation of the minimally invasive surgery. Is minimal invasive approach? Yes, but not so minimal. We always need to open the veins and to resuture. And what about complication? Suture-related, so we need to drain in the most of cases. Well, what about follow-up? About suture? Our experience in endoscopic treatment show that the stenosis is also possible in the ureteroscopic tract, but we don't have to. We have to remember that also in minimally invasive surgery this is possible. Another limitation I would like to keep in mind this very important aspect is that the population that we go to treat is a population with a very high recurrence of the lithiasis. So what can we do for the recurrence in chronic pathology? We can do a redo minimal invasive approach, or you have to change approach. It's important to remember that the minimal invasive approach don't preclude any other endurological technique if the recurrence occurs. So, as I said, Dr. Tagliani speaking yesterday about this, the role of the minimal invasive surgery in the urinary lithiasis tract is a little battle. When we decide to choose this approach, we have to ask ourselves a good question. Who is the patient who can operate with this technique? We need to have a very accurate patient selection. When we have to know if there is any pathological metabolic situation, if the patient has a previous procedure, and what the experience is very important to choose laparoscopic, transperitoneal, or retroperitoneal approach. In conclusion, the minimal invasive surgery is not the first choice, or only in a very little population, but in a selected patient, it can be a very reasonable and safe minimal invasive option in pediatric population. Now, I hope that some take-home message about when minimal invasive surgery becomes a very good choice or the first choice when endoscopic techniques are inappropriate for excision based upon age and weight, whether we found a very large stone, when we have stone in anomalies of the urinary tract, when the stones are very complex and require a lot of treatment with endoscopic technique, and when the endoscopic technique are failed. It's important to remember that the minimal invasive surgery requires experience, and we can use a unique technique or in combination with the other technique. Together, I think we will. So thank you so much for your attention.
I have to congratulate with all the speakers because we are on time and we have time for some discussion. I give you this Adam to moderate and to do conclusion and discussion with all those things.
It's working. Do we have any questions from the audience?
Well, short.
Well, how are you? You should have a question.
Dr. Ferretti, very nice. Congratulations, all of you, because we cover all the technique, minimal invasive technique in pediatric urology for the stones. Very happy with this. I like it more a lot, the combination in between the ureteroscope and the mini-pair, or that's what you do. What is the limit of age that you have to treat the patient for tuberculosis with in combination? Because the limit also in flexible
Yes.
ureteroscope.
Yes. Generally, you need, for example, the presenting patient up to 3 years. Up to 3 years is the limit for combine. and is better between 3 and 5 years after a stent procedure, because if you want to put a urethral access sheet, it's better, but it's not mandatory, because you can go up without urethral access sheet to combine. Today we have a very important scenario of disposable, flexible ureteroscope. For example, we have a 7.5, and I can say the manufacturer because it is exclusive and is by Usen 7.5 digital flexible ureteroscopy. It's the smaller one on market. And of course, today there is a very run for this disposable instrumentation.
And to Adam, what caution do you use during the laser fermentation? I mean, I saw that you put a shield. How do you measure the pressure? Yesterday we saw a very nice presentation of our colleague for the operation in kidney. Do you use some tricks, tips and tricks to check what happened for the warming and also to the pressure?
Yeah, that's the real problem, how to assess this situation. We don't have a specialized equipment. During the workshop, as I said, that there is the pressure measurement possibilities. I think that we should introduce it in all of our endoscopical procedures. And the laser, we try to not to exceed in kidney the 24 watts, and in the bladder the 32 watts. This is the maximum. For example, what the laser company told us that we cannot exceed, so we are not allowed to exceed those limits.
Renato, thanks for all the speakers for the beautiful presentation. Just two strategic questions. According to the guidelines, the choice is very complex, but according to the guidelines, stones below 2 centimeters first attempted by ESWL. So is there still room for ESWL for pediatric stones, or we are moving more towards endoscopic treatment? And the second question is, probably over the past years, we actually moved from ESWL to intrarenal surgery, but for complex stones, should we prefer PCNL instead of repeated intrarenal surgery?
About the literature and experience, the SBL are very high recurrence. So the limit is very in the pediatric population. The treatment, we can make a lot of treatment, and when we choose the technique, we have to remind that it's very important to have a very high twin stones. So in this case, if it is possible to have an endourological technique, I think that is better, because the high free rate is the definition of the technique are very high at the other hardware.
We are performing around 120 cases in the ESWL every year, and there is still place for it, especially according to the literature. In our experience, the younger children has the greater chance of success in ESWL. So if you have a small child, even with a big stone, it won't be a problem. And those child are moving so much, so the spontaneous passing the fragments is not a problem for them.
Yes, I think that the shockwave is not high, but there is, for example, in our reality, we have not a pediatric surgery unit. So the baby need to come to our institute in the adults. And for example, I think that there is a balance between the number of shockwave sections, the number of narcosis, and so on. So if you want to have a stone-free rate, a very high stone-free rate in one session, sometimes for stone more than 2 centimeters, it's not possible to think to shockwave. I believe in this. Of course, I'm not a pediatric surgery. And today, for example, for answer to your question, what about 2 centimeters, for example, a cutoff? Today, we have a laser technology, high-power chromium laser, but especially super pulsed thulium fiber laser, TFL, that are able 4 times more than Olmio to dusting. So it's very quickly, and for example, why not? One session of intrarenal surgery is probably also a choice for a 2 centimeter stone.
Yeah, so things are changing. Probably, I think that also guidelines will be reviewed because with new technology, new chance of one-shot stone-free cases is available. Otherwise, yes, we will repeated in anesthesia, not easy, stress, so a lot of troubles. So we are reducing this indication.
I can completely agree with Paolo. The techniques are not so different for the many years. However, the devices which we are using for the lithotripsy are right now the more powerful and are decreasing the time of the surgery, and this is very important, I think. Would you agree?
Yes.
For Paolo, very short question, because you were a pioneer of minimal invasive, okay, because you started a lot of years ago, but you was also an open surgeon, okay? Just because you are on the surgeon. I ask you very fast, is there now, to you, a space to open surgery for these cases?
Personally, I don't think. Personally, I don't think. I am open surgeon in the past. Personally, I don't think.
I think that there's space for a robotic approach, maybe.
But laparoscopic.
And robotic with the robotic.
Laparoscopic, yes, could be, but not open. Open, I don't. What does mean?
When we are in.
So, thank you, all the people. I think that we need experience, knowledge, devices, money, and probably we should centralize these difficult cases, which is increasing. I don't increase cases in probably in stone centers that should be everywhere spread on our countries. Thank you.
And I also think that the parents, when we are adopting the procedure, that it will avoid, for example, one surgery when the child is around 5 years old. We should remember that when he will be 8, 10, he can have another procedure, so the choice of the procedure is also very important for the future. Thank you so much.